Welcome all. Good evening to one and all. World Kidney Day is being celebrated on second Thursday in the month of March every year. And this year it falls on 13th March 2025. And this year's theme is Are Your Kidneys Okay? Let us detect early and protect kidneys. Slides, please. Slides, please.
Ranjini, you have your slides, you share them. If Saurabh is not able to.
Okay.
There.
Yeah. Yeah. So every year we have World Kidney Day being celebrated on second Thursday of in the month of March, and this year it falls on 13th March. Uh, and this year's theme is Are Your Kidneys Okay? Detect early, protect kidney health. So various activities happen throughout the world, and we have in this year the activities are in the form of seven sub themes. Next slide. So we are having in the form of we do in the form of creating awareness about our kidneys, telling them about the high risk factors being diabetes and high blood pressure. Systematic screening is there, and also we encourage activities where we can encourage preventive behaviors. We also educate medical professionals and stress on the important role of local and national authorities. And last, the important one, the being the how to become an organ donor and encourage transplant, because it gives a way of life. Next. So, Win India, Women in Nephrology India is holding this webinar as part of World Kidney Day advocacy activities, and I take pleasure to invite all of you for this interactive session, which consists of mainly first a panel discussion on transplant, question and answers. There'll be a quiz actually for the patients, and there'll be a talk about organ donation and how to become organ donor, followed by a short documentary, and we'll close this session. So once again, I welcome you all as part of World Kidney Day Chair this year. I heartily open this session. So I request Dr. Lavi Gaur to take over from here.
Thank you, Dr. Ranjini, and good evening, everyone. So, as Dr. Ranjini highlighted, that today we have all gathered to discuss a global health challenge that we have been dealing with, which is chronic kidney disease. While there have been many advancements which have improved our understanding about the disease process, and there have been many discoveries of new medicines which have improved the management of the disease. But despite this, many patients still end up with what we understand as kidney failure and require some form of dialysis or transplantation. So let us take this opportunity to understand the disease, and there is no better way than hearing from the best of India in our panel today. For this panel discussion, I welcome our esteemed panelists, Dr. Arpita Ray Chaudhary, Dr. Shruti Tapyawala, Dr. Vasanti, Dr. Manisha Sahai, and Dr. Vijay Lakshmi. We look forward to learn more from you. My first question to Dr. Jay Lakshmi, ma'am, what is chronic kidney disease and what are stages that the patients have to deal with?
Good evening, everyone. It is an honor to be in this forum. Basically, the chronic kidney disease is the one where the kidneys have been having trouble for quite some time. And we call it a chronic kidney disease when there has been problem for more than 3 months. And in these patients, we have the kidneys which are failing, need not necessarily be continuously failing because they might be in various stages of chronic kidney disease. We have the stages 1 to 5, basically with which is classified with the GFR. GFR is nothing but the glomerular filtration rate, which means that the amount of filter that's happening in the glomerulus every minute. So based on that, which we use with the creatinine of the patient, we have 5 stages. And once the patient reaches the stage 5, then beyond that, we call it as a end-stage kidney disease. So this is a chronic kidney disease where the patient has been having either a proteinuria, or a raised creatinine or any abnormalities in the kidney for quite some time, especially more than 3 months.
Right, ma'am. So we have often heard from many experts that in early stages of the disease, there might be very little or no symptoms. But my next question to Dr. Sahai, ma'am, what is basically what do the patients feel or face when they are actually suffering from end stage kidney disease? Manisha, ma'am, can you hear me?
Yeah, am I audible?
Yes, ma'am, you are.
Yeah, so good evening, everyone. And thanks, Dr. Jayalakshmi. You explained very well what is chronic kidney disease and what are the stages. So I would like to highlight here that in advanced kidney disease, you may have multiple symptoms which may be related to the kidney or not related to the kidney also. And this is very important for everyone to understand because people correlate that kidney disease is associated with decreased urine output or the urine output should be minimal and the patient should have swelling. That's what most of the people feel. But what the people and even the general practitioners may not realize that even patients with end stage kidney failure may have a good urine output. There may not be any swelling. In fact, they may have many other symptoms pertaining to other organs. So remember, kidney failure is a systemic disease. It involves all the systems in the body because kidney is the filter for urea, creatinine, all poisons, and there is accumulation of poison which affects every system in the body, be it the lungs, the heart, the brain, or your skeletal system. Because kidneys have a lot of functions apart from clearing urea and creatinine, they control the blood pressure by excreting sodium, so patients can come with severe hypertension. They may have loss of appetite because of accumulation of toxins. In addition, they may have bone pains because kidneys have an active role in formation of vitamin D. And you know that kidney is also involved in blood formation through the hormone erythropoietin. So patients with advanced kidney failure can have anemia as well. And many times we see patients who have been treated for
Hello.
anemia with iron, with erythropoietin, with so many other things, in fact, even blood transfusions, and never realizing that the whole symptomatology was because of kidney failure. So, pruritus, itching. So, patients keep on going to dermatologists multiple times for pruritus. Am I audible? I mean, there is some disturbance on the line.
You are audible, ma'am.
Saurabh,
Okay.
you can mute all
So, can the
participants.
others mute? I'm getting confused as to
You
please
will
mute.
have to mute Saurabh ji, except panelists mute everyone for now.
Yeah, so
Because
as I was saying, skin may be involved. Patients may come with pruritus. So you can see there may be loss of taste. People may not want to eat. There may be loss of, libido. So all those sexual life gets disturbed. So kidney failure is a systemic disease, and these are the symptoms in advanced kidney failure. But before I end, I would like to point out that kidney disease in early stage is completely asymptomatic. There may be no symptoms at all, and it might be quite frightening. We see many patients with history of hypertension since a long time never even tested for a kidney disease. Patients with fractures, growth retardation, children with growth retardation, recurrent urinary tract infections, never tested about kidney disease because nobody thought of the kidney. So it's very, very important that those at high risk for kidney disease should be tested whether they have symptoms or not. And I'm sure during the course of this discussion, we will find out which are the patient groups whom we need to test even when the symptoms are not there. So thank you.
Thank you, ma'am. This was a very insightful discussion. And in fact, to re-emphasize again, it is absolutely uh, important for everybody to understand that detection of kidney disease in the early stages comes more often as a surprise diagnosis, and sometime and more often the patients with advanced diseases have more than several symptoms to face at the same time. So, Shruti ma'am, what are the options that the patients with end stage kidney disease have for their further treatment?
first, Lovi, thank you for the question. First, let me just tell you all that the chronic kidney disease slowly progresses to end stage kidney disease, like Dr. Jayalakshmi and Dr. Manisha have said. That once you have a chronic kidney disease, as displayed on the screen, the kidney function slowly deteriorates, and uh, what happens is that later on there is a stage where your kidney function is almost less than 15 mils per minute or less than 15%. at which point of time your body cannot withstand the loss of kidney function or the inability of kidney to work for you. At that time, the patient is at a risk of having life-threatening medical complications. And this is the time when we tell patients that your kidneys are almost dead and you need something known as replacement therapy for your kidney function. Now, when you think of replacement therapy for your kidney function, there are two ways. One is you can replace it naturally by giving a new kidney, that your kidney is dead and you get a new kidney, or you artificially try to do the work of the kidney. How would you artificially try to do the work? One is by hemodialysis, by cleaning your blood via a machine, which is known as hemodialysis. Lay people call it blood dialysis also. It is sending the blood through a machine, through a filter, where all the toxins which your kidney is supposed to remove along with excess water, electrolytes which are harmful to the body, calcium, phosphorus, all this is managed. That is known as hemodialysis. A person has to come 2 or 3 times a week and get the blood cleaned of all the toxins which have accumulated. Second type of dialysis is peritoneal dialysis, wherein a small tube is placed in the stomach. Medicated fluid is put inside and it is kept there for some time. It accumulates all the toxins and the fluid is removed. This can be done at home also, which is very simple. These are two types of dialysis which can be done, and transplant remains the best option because with transplant you get all the functions of the kidney which you have been living for all your life. Dialysis gives you only 15 to 20% of the kidney function which you should be getting. Hence, transplant overall remains the best option given that it gives you near normalcy of life. Over to you, Lou.
Thank you, ma'am. As you have wonderfully headlined the fact that transplant remains the best modality of treatment of end-stage kidney disease, my question to Dr. Jayalakshmi, ma'am, what are the benefits, overall multidimensional benefits that transplant has to offer over the dialysis modalities?
Yeah, actually, when we take the dialysis, the patient will have to actually go to a place and have the dialysis done. And this is an artificial thing that happens, which replaces kidney function. But dialysis does not have it cannot replace all the kidney function. As Manisha madam had told earlier, kidney has got multifarious functions. So dialysis can only remove the waste and remove excess water and balance the electrolytes. But then we need to give some erythropoietin for improving the anemia. We need to take care of the bone disease also. So even then, a dialysis, with all these accessories will not be adequate because nothing like having another kidney. So transplantation certainly has a lot of benefits because the patient gets a new kidney that is going to function like his own kidney. So we have a kidney that is going to function in the place of the non-functioning kidneys. So the patient can have a near normal life if he is going to have this kidney properly accepted. So for that purpose, we will do a lot of investigations to see if the kidney that is going to be placed in the patient's body will be accepted by the patient. So transplantation certainly is a better option. And many of the studies that I've done have told that transplantation is always better than doing dialysis.
Absolutely, ma'am. Wonderfully taken points. But Dr. Manisha, I think, ma'am, in your very vast practice, I think even you would have encountered the moment we talk about and explain about transplantation, the first question that comes across from the table is, "Ye kidney kahan se aayegi?" So where do we get the kidneys from?
It's a very pertinent question. So kidney can come from multiple sources. Now it can come from a living person or it can come from a person after his or her death. So from living person, you may ask, can anybody donate a kidney? So remember, again, I would request the others to mute, please. So among living persons, the kidney can be taken from a living related donor. And what do you mean by a living related donor? Obviously, relation means in blood relations. Now, living related donors can be near related. So as per the current law, what do you mean by near related? Your father, mother, your siblings, brothers, sisters, your children, and even your grandparents have been included under living near related donors who can give the kidney, and the transplant can be done in any hospital without any special permission. Another important thing is a spousal donor. What do you mean by a spousal donor? Either the husband donates to wife or wife donates to husband, and this is also legally accepted by the current laws. Now, what do you mean by living related who are other than near related? Means little bit distant related. So can transplant be done from these donors? For example, from maternal aunts, paternal aunts, uncles, or maybe for friends. Can we do a transplant in India as per the current guidelines? Yes, you can do transplants from unrelated donors also, but this is a special category of transplant. And again, you have to take legal permission, committee permission, state authorization committee permission for these type of transplants. So living donors, you have understood. And the criteria generally is more than 18 years of age, and the upper limit generally we take up to 60, 65. The living donor should also have perfectly normal kidney functions and should not have other sicknesses, because we want to protect the health of the donor also after donation. So we have to take care of the recipient as well as the donor. Donor should also be fine after donation. So this is the main essence of living donation, no harm to anyone. Now coming to other types of donations, for example, from a dead body. So here again, you have two types of dead persons. One is brain dead person, in a simple manner, where the heart is beating, the brain is not functioning anymore. So this is called brain stem death donor or brain dead donor. And you must be aware, many of you must have heard of different programs running across the country where after death, one donor can save the lives of so many people. 8 people, they say, but now everything in the body can be donated. Liver, kidney, heart, lungs, pancreas, intestine, everything, even bones are also being utilized, even tissues are being utilized. We all of us know about corneal donation. So this is about organs which can be donated by a dead person. And I told you that brain dead person can donate organs. The next question would be, what about people where heart is not beating? Can we have donations from non-beating donors? Non-heart beating donors? Yes, that can also be done. Non-heart beating donors, transplants are happening in Chandigarh. And in other parts of India also, they will soon get started. Only thing, we need a better system to transport, or for example, you have a death on the roadside, to resuscitate the donor bedside. So that's called donation after heart death or donation after circulatory death. So these are the different types of donors, living donors and deceased donors, as I explained in a nutshell. I hope that makes things clearer for you.
This has been a very good summary of overall where could the kidneys could actually come from. As ma'am, you have highlighted that do no harm principle applies to any treatment that we provide and holds true even for living kidney donation. But often the questions from the other side of the table include that how would the donor be followed up? What are the risks for the living kidney donors? So I would pose this question to Dr. Shruti. Ma'am, what could be the apt answers to some of these queries?
फर्स्ट ऑफ ऑल पेशेंट्स आस्क मी कि मैं इतना बीमार हूँ, मैं ट्रांसप्लांट कर सकता हूँ क्या, मैं डायबिटिक हूँ, मैं कर सकता हूँ क्या. यू नो, पीपल हैव these myths that if you are unwell you can't do transplant. But then I'm talking about both the sides, recipients, meaning patients who can go for transplants, and donors who can give kidneys. So anyone who does not have a cancer, who does not have an infection which is not healing, yeah, there is not a situation where some other disease is going to decrease the life of the patient, can go for transplant. So do not think that I am unfit for transplant, mera kya hoga. Nahin. Everyone, unless proven otherwise, can go for a transplant. Now, who can donate is another question. So, donor eligibility, we usually want that someone is baseline healthy, living a good life, no major illnesses, mild blood pressure, mild thyroid illnesses is okay. No active cancer anywhere in the body, no active infections which are not healing in the body, Nowadays, mild diabetics are also being taken as per the world literature and for the guidelines. Mild diabetics who do not have diabetic damages to the kidney or to any other part of the body and who are leading a very healthy lifestyle can be also taken considered as special cases for donors. So we do not rule them out totally. So even if you have any willing donors in the families who are saying that, oh, I'm willing to give, I have a good sugar control, I have no problems, I'm living a healthy life, yes, we do consider them. And to mention to you, we have at least 70 donors in our program who are diabetics, who have donated at least average 5 to 10 years ago and who are doing well. So we have to choose them well. It's not that all diabetics are taken, do not take me wrong. So baseline healthy people, baseline willingness to donate, because donating a kidney is not going to harm anyone if chosen properly. The last criteria which we do is a DTPA scan, which is a nuclear scan. This scan tells me how much your each kidney is functioning, because I want a kidney function of at least 80% and above. And if that is there, I know that one can safely give and one can safely receive without having a problem later on in the life. So this will purely summarize as to who can receive and who can give.
Absolutely, ma'am. This has been a wonderful summary. The next question that often the transplant patients as well as the family has, that what precautions they would need to take once the transplantation is done. Dr. Jailakshmi, we would like to hear more from you on this topic.
Basically, when you take it from the recipient's point of view, so that we'll discuss first. From the recipient's point of view, the recipient should understand that he has to take medicines continuously throughout. So he'll be given a set of medications which will prevent rejection of the transplanted kidney. So he will be given a medication in such a manner that he'll be advised to take how much to be taken and when it has to be taken, before food or after food. All these instructions will be given and he has to follow it meticulously. That is very important because the blood levels of all these drugs should be maintained properly so that it will prevent rejection of the transplanted kidney. So from the recipient's point of view, the first and foremost thing is adherence to medication. Second thing is, he must understand that these medications are immunosuppressive drugs. So these drugs may be, in case immunosuppression is a little bit too much, he can land up with infections. So the first thing is to prevent infections. So he must have proper food, properly boiled water, and he should stay in a room where it's very clean and neat, and his toilet should be cleaned properly every day, and he must not unnecessarily mingle with people in the first few months, especially. He must wear a mask when he's going out and meeting somebody, even inside the house. And it's very important that all preventive measures are taken by the patient to avoid any infection. So, taking of immunosuppressants is most important, and prevention of infection. The third thing is he must know when to report to the doctor. Which time, whenever he gets a fever, whenever he gets any loose stools, any cough, any breathlessness, and whenever the urine volume comes down. So there will be a lot of warning signs which will be told to the patient as the transplant is getting done. So these warning signs should never be ignored by the patient. This is the early stages, especially in the first 6 months, since the peak immunosuppression is high. This is the time when the patient will have to be really very, very careful and follow everything verbatim as per the doctor says. Later on, also, the patient should be very sure that he is taking the drugs properly and doing investigations regularly as per the doctor's advice. So, doing investigation is also very important right from the beginning. So, he must understand. So, the doctors always spend a lot of time with the patient to tell him what is happening, what are all the things the patient has to follow, and make him understand the treatment. Because it's very important that the patient understands what he does and the importance of each and every act that he is going to do. When it comes to the donor, supposing we're having a live donor, the donor also needs to take some precautions. He must know when to get back to his job and when he can, which frequency he has to come to the hospital for screening, for basically a urine analysis, repeat creatinine investigations. And if she is a diabetic or a hypertensive, need to monitor his BP and sugar very closely so that everything is kept in good control so that the remaining kidney does a good job, doesn't get into failure. Moreover, even in the long run, the donors have to be visiting the doctors every 6 months just to ensure that they are doing well. So these two things are very important: adherence to medicine, keeping track of the medical records, and just listening to what the doctor is telling and obeying whatever the doctor says, and knowing the warning signs and getting back to doctor whenever there's a problem. And they should never take any medications without the advice of the treating doctor, because there can be a lot of drug interactions. So everything they should consult the treating doctor and then only go ahead.
Thank you, ma'am. Actually, this cannot be more emphasized further that in real life, the donors are often good Samaritans who donate and often forget that they have to take care of themselves. But as important is the follow-up of the kidney transplant recipient, equally important is the follow-up of donors, and this requires an effort from both the doctors as well as the donors. They have to take care of themselves. But the most common, the other common question that most of the patients have is कि हमारी किडनी एक बार ट्रांसप्लांट हो जाएगा तो हमारा काम कितने दिन चल जाएगा. So, Dr. Manisha ma'am, what do you have to say about this?
So, Dr. Lavi, very pertinent question and a very frequently asked question. So what we have to tell them is, see, it depends. In living donor kidneys, they may last for a lifetime also, but there is something called, we talk about half-life and all that, 22 years. For deceased donors, maybe around 15 years. Literature says so many things. Spousal donors, again, you have a good lifespan. So basically, nobody can predict. But the answer what I generally give to them is that if you take care of the kidneys properly, your kidney properly, as the previous speaker is beautifully alluded to. See, we can do whatever is in our hands. Leave 10% to God. 90% is in your hands. So worry about the 90%. Do what you can. Focus on what you can rather than thinking that 10%, whether it's going to survive or not survive. Keep your blood pressure under control. Take your immunosuppressive medications. Take your vaccinations properly. Follow all the hygienic protocols. Maintain your glycemic control if you are a diabetic. So these are common things. Maintain a fit lifestyle. Control your BMI. We should tell them what their ideal weight should be. Instead of just telling them that control your weight, give them a figure. 160 centimeters height, 160 minus 100, 60 kg should be your weight. You need not be scientifically right, but tell them approximately some figure so they know, okay, I'm 80 kg, I have to come down to 60 kg. Give them reasonable targets. Explain to them about diet. Maintain a proper diet. Transplant doesn't mean you have freedom to eat everything. You still have to stay fit. In this day and age, the most important and neglected thing is your diet. And in India especially, it's more so. So that's very important. Again, cut down on salt, oil, half liter per month per person. Those things are routine for everyone, even for transplant patients as well. So all these things are important. And as I said, if you follow all these precautions, I think the kidney may even last for a lifetime. We have a transplant patient transplanted in government sector in Osmania, 1982, and still going strong. Brother donated to donor. So you have many such examples. And many times what I have found useful is the patient interacts with the doctor, and if the patient interacts with a post-transplant patient who has been doing well, it's a big morale booster for many of them. So coming from a doctor, they may believe, oh, okay, doctor doesn't experience what we are experiencing, but a patient tells him or her that I've been doing well and I've been following these precautions. It's a big, game changer for them as well. So the simple answer to your question is it varies with the patient. The scientific literature says they talk about half-lives and all, but again, you may live with one kidney for life. In case the kidney fails, there is always hope. There is hope for a second transplant, a third transplant. In fact, literature reports 4 transplants in a single person. So I keep on telling the patients, see, you should have hope. It's not the end of life. Try best to maintain the first kidney transplant as long as possible. In case it fails, still there is always hope. So that's how I answer the question. There may be different opinions and the different ways the patient is explained, but this would be the essence of what we tell the patients.
Absolutely, well said, ma'am. These are some very important. This cannot be a single answer to this question. The situation varies and so does the graft half-life. But many times we come across a situation that the blood groups are not matching within the family members. Oftentimes, a patient has had a history of multiple transfusions. They are turning out to be cross-match positive either because of any kind of previous history. So, is it possible for everyone to get a transplant even if they are facing one or the other of these situations? I would actually ask this question to Dr. Arpita, who has joined us. Have Arpita ma'am.
Yeah. So, yeah.
Hello.
Hello. Lavi, please repeat once your question.
And oftentimes we come across a situation where the patient says that everybody in my family has a blood group which is different from what I have.
Yes. Yes.
And
So, a blood group incompatible transplant. What we can do if the blood group is not matching? So, uh, there is one form of transplant where we use some desensitization. Means when the blood groups are against, the the recipients are likely to develop antibodies against those blood groups, and ultimately what happens at that time, those antibodies may add to rejection of the graft. So that is always an anxiety. So we need to downscale the antibody response. So we use some medications which can downscale the antibody formation response. With that, we can do ABO-I incompatible. A2 seems to be a very weak antigen. In that ABO incompatible transplant, we may not have to use very large dose of immunosuppression. Initially, when we started this type of transplant, we used to give high dose of immunosuppressants. Now we have come down to a minimum so that it hurts the recipient least. There is another form of transplant possible in ABO-I incompatible people. Suppose one set of recipient and uh, donor is B and A, and the B cannot give A. It will require large amount of immunosuppression, which the family doesn't want to bear because of cost issue, might be because of the danger of precipitating infections and all. Then what we can do, there might be another set of patients who have just the opposite thing, A group recipient and the B group donor. So then these patients can exchange their donors. So a B will be giving B and a A will be giving A. We call it a swap donation. And recently in Maharashtra, three highly sensitized patients, by help of Dr. Shruti Trapiwala, who was in our group, have been transplanted with very low immunosuppression, though they were highly sensitized people. So, when the blood group incompatibility or HLA incompatibility is a barrier to transplant, then this type of software based allocation of kidney can help the recipient to get the kidney from a donor who is maximally matching to the recipient. So, the fear of getting very high immunosuppression, the fear of precipitating infections and losing life down the way to either infection or losing the graft due to rejection, both the fears can be minimized. Thank you, Lavi.
thank you, ma'am. This was a wonderfully answered question. So, while we have discussed so much about the living donation, there are certain questions that even the general public has. What if one wants to donate after their death or wants to pledge their organs? So, my question to Dr. Shruti, how can somebody do this? How can somebody pledge their organs and go ahead to promote this deceased organ donation program?
Okay. Thank you so much for the question. We had reserved this as a little session later, but we can take it now. So anyone can pledge their organs on any time while they are living. If they have this intense wish to help people and they are not able to help a living person because they do not have a relative who is suffering. Like there are sometimes you can donate only a kidney or a liver when you are living, but when you are dead, you can donate your whole body. We have at least 13 or 14 hand transplant recipients where people have had accidents, they have been amputated, and they're getting a new chance to life. Heart, lung transplant, skin, bone, cartilage, heart, liver, kidney, pancreas, intestines, everything can be donated. So, yes, anyone can be a donor. When we have a donor in the city or in the country, there is a system in place which Dr. Swarnlata is going to tell us in the next few minutes. But if one wants to be a donor, it is very simple. You can pick up an organ donor card from any hospital which is nearby to you. Any major hospital will have organ donor card, and this is a donor card from Maharashtra Zonal Transplant Coordination Committee. I will also show you the Noto website where you can go and pledge your organs. But the important things first, you have to take a decision first that yes, I want to be an organ donor. Pick up the card. On the card, you have to write your name. You have to write that I have consented to donate my body or XYZ organs, and then you have to share your decision. Why do you have to share your decision with your family? Because in event that you are no more, God forbid, you have had an accident or something like that, and you are admitted to a hospital, you are not able to convey your decision. Your wish will be conveyed with this organ donor card. But if your family member, who is your power of attorney or who is your next of kin or your immediate relative, say husband, wife, parents, children, if they say no, then the doctors or the hospital still cannot take your organs and donate it to someone else. So it's important to involve your family in your decision and take the signature of the next of your kin that, okay, I have shared my decision with my wife or my husband or my parents or my siblings or my children. So that hospital or the medical fraternity will be able to ask them that, look, your near and dear one is no more, but it was his or her wish to donate. Would you also side with his decision given that you have been told about this decision further? Sign that card, keep the card with you all the time. This is extremely important because if you do not keep the card, the treating people will not know about your wish. So wherever you are in the world, it is valid because it's a wish. Okay. Now, few other things about the card. Okay. This is a voluntary act. Very important. The donor can approach any organ transplant center. You need not register somewhere. You have to just have a card like your license you have with you. The decision can be done by a lawful custodian. It is not a legal paper. Very important. You can always tear it and throw it if you do not wish to, even if you have signed today. It does not have a legal binding on you. You can change your mind anytime, but this is a noble act because once we are no more, the body is not going to be of use to anyone. It is going to be buried. It is going to be cremated. It is going to be lost, and the organs are going to be lost with it. So, when there is time after death, when the body is no longer useful to us, it can be useful to at least 15 to 20 other people. So, this is very important for you to understand. This is the Noto website. You can simply type Noto organ pledge and you will be taken to this page, and you can click on the notoadmin.gov.in. You will come to this page. You can
Ma'am,
register and pledge. So Dr.
ma'am,
Vasanti, who is with us, has been the ex-Noto director. She's also going to tell us a little bit more about this, but this is how you can be an organ donor. And very important, if you are not fit yourself, you're not going to be able to donate. So try to keep yourself fit so that when it is time to donate, the doctors can say, oh, the organs are fit, you can donate. So remember, keep yourself fit, and then you can sign an organ donor card and and pass on the life. Thanks, Claudia.
Thank you, ma'am. This has been very informative. The organs, anybody in India can pledge their organs, but it is a wonderful distribution system that helps in organizing the system. So, without much ado, I would straight away pose this question to Dr. Vasanti, ma'am. How does this organ distribution system work in India?
First and foremost, what I would like to impress upon in relation to what Dr. Shruti was saying about pledge and other things. See, it would be good for allocation in times to come that the pledges are all in the same website of Noto, so that if they are also linked with Aadhaar and the NHA is monitoring that, then uh, all the registered hospitals, who are doing transplant are linked with Noto. And at a later point in time, if we are able to succeed in linking the pledges also, if these hospitals can verify by uploading the details of a particular patient who is admitted in an ICU and is declared brain dead, whether he or she has registered as a donor, then getting the consent would become easier for donation. Because as per the Act, we are supposed to ask the family whether the concerned individual had pledged. So that way, the getting the consent would become easier. Then, after the brain death is declared, first at the level of the SOTO, the allocation is done. So one would have to inform the SOTO of the state that there is a brain dead patient in our hospital, and we have facilities for kidney, liver, heart, whatever, and these are the organs that are fit to be retrieved and are likely to be retrieved, and therefore the allocation may be done accordingly. They can retain one kidney and all the organs for which they have facilities for transplant. If by any chance the SOTO is unable to utilize any of the organs, usually kidneys and livers are utilized in the state of origin. It is the heart, lung, and if the relatives have given consent for, small bowel, hand, etc., then they may be distributed. And if facilities are not available in the same state, then it could go to the region through which it can go to another state, or it can go to Noto, from where it will be distributed nationally. Most important from awareness point of view is, we have the school health cell and various things. Swarnalata would be able to contribute on that, because Telangana has started its program through the schools to raise awareness among children. And an important thing among the medical graduates at all postgraduate levels, now they have, including in the curriculum, to have the postgraduates trained in organ donation. The THOA is already included in the MCI curriculum 2018. In addition to that, practical hands-on training is proposed. So with all this, I do hope that retrieval would certainly be. I am trying, and also in various centers in the US. For example, Yolanda Becker, who should have come last year in the WIT program in ISOT. So she was saying she heads Life Gift, where they do exclusively, retrievals. So they have retrieval surgeons. So like that, if we are able to develop retrieval surgeons, then people would not have to catch flights, go to retrieve and all that. It'll be a lot of, obstacles broken and facilitation done to ensure retrieval in time as well as distribution of the organs in time. And I think that would go a very long way in increasing the number of transplants in our country and saving the lives of many, many patients.
Thank you, ma'am. It is always a pleasure to hear from you, and same this time. I would take this I would take this opportunity to thank all our esteemed panelists. We certainly had a lot to learn from all of you, and I'm sure that the audience also shares the same thing as what I feel. And thank you, everyone, and thank you for the opportunity to share this opportunity to interact with you. Thank you so much.
Thank you, Larry.
Thank you.
Thank you very much. And thank you
Yeah,
for
you can.
informing me in time. I've been running a hectic schedule, more of travel. Right now, I'm traveling to the Mahakumbh. So thank you for letting me know in time so that I could join. And it was indeed a great pleasure.
Louis, can I
have two
just
questions. I have shared in the
have a
chat.
bit of information share?
Yeah, please go ahead, ma'am.
Yeah, actually, we have an equal number of non-transplant retrieval centers. So here what we have is that we have a good number of centers in medical colleges who do transplantation. And in those centers where we do not have transplantation surgeons, we do retrievals and send the organs to nearby centers, nearby transplant centers. So as madam had suggested about the retrieval surgeons, we have non-transplant retrieval centers, a good number of them in our state. Just want to highlight that point.
Lavi, there are two
Well said,
questions.
Madam Dr. Jayalakshmi.
Thank you.
So I would now hand over the dice to Dr. Sonal, who is going to conduct a very exciting quiz. Over to Dr. Sonal.
Good evening,
Lavi,
everyone.
okay, there are two questions in the chat box. If you can finish that before the quiz.
Absolutely, ma'am. Absolutely.
That will keep happening
Otherwise,
during
we can take the
it
chat
can
box for the
keep
next session
happening.
also.
Yeah.
Okay.
Yeah, I mean, that would be better because
Okay,
time.
okay, sure.
Good evening, everyone. So today I've been given duty to conduct a quiz for this occasion on World Kidney Day, and so let me start. Is it okay? The screen?
Yes.
All other slides are also seen over.
Yes. So make it full screen. Enable editing you'll have to do and then make it full screen.
Yeah. Is it okay now?
Yes.
Yes. Good evening, everyone. So this is an interesting quiz for all our participants today. This would be an interaction. This would also be learning plus it will be a fun. So let's start with our first question. The question is, what is like the kidneys are a part of which system in our body? Well, it is a reproductive system, respiratory system, GI system, or urinary system. I would give 5 seconds or 10 seconds for you to react. You write your answers in the chat box, and
Urinary system.
able to give any results or anything, but I would announce the answer after every question. So you can just tally and see how much you can, how many questions you have solved and how you know the subject. So the answer to this question is the kidneys are part of the urinary system. The urinary system is made up of 2 kidneys, 2 ureters, bladder and ureter. The ureters are the tubes which carry urine from the kidneys to the bladder, and bladder is the one which stores the urine. and there is a sphincter to the bladder which controls the urine passage automatically, and the urine is passed to the urethra. So this is the complete urinary system, which is known as a urinary complete nephrourinary system. The second question is, where are your two kidneys located in your body and how big they are? Option A is on either side of your stomach, the size is of your head. Option B is it is in your back, the size is of your fist. And option C is in your back behind your lungs and the size is of your eye. So this is a very simple question. The answer to this is it is in your back and the size is of your fist. They are around 9 centimeter in the size and are situated on the back, and they are like a clenched fist. The question number 3, how many liters of the fluid does the kidney filter every day? Whether it is 50 liter, 100 liter, 150 liter or 200 liter of fluid is filtered out by the kidney per day. The correct answer to this question is it is 200 liters. So the almost 200 liters of the blood, 120 ml per hour is the blood flow to the kidney. And this amount of it is filtered, and of this 180 to 200 liters of the urine is produced, which is then reabsorbed, and only 2 liters is excreted. So the amount of filter is very high, but most of them it is reabsorbed. It is returned back into the blood, and only the waste is excreted through the bladder into the urethra, and urine is produced, which is around 1.5 to 2 liters per day. How much urine do kidneys produce in normal healthy person each day? It is 500 ml, 1 liter, 1.5 liter, and 2.5 liter. These are the options. How much is the urine produced per day by a healthy person? And correct answer is 1.5 liters per day is the average urine output per day produced by the healthy person. That is around 6.3 cups of urine. What is the structure and functional unit of the kidney? Whether it is glomerulus, whether it is nephron, renal capsule, or Bowman's capsule, which is the structural and functional unit of the kidney? And the answer to this question is nephron. Nephron is the correct answer. Glomerulus is the only part which is filtered, whereas the nephron is the part which is complete. It is the filter, glomerulus plus tubule. And it is the most important functional unit of the kidney. The question number 6, which substance is not normally found in the urine? So you will, if you do analysis of the urine, what you will not be able to find? It is urea, glucose, creatinine, or sodium. And one more option is cholesterol. One more option is cholesterol. The correct answer is glucose. Also cholesterol you will not find, but glucose is like if you are a normal healthy person, you will not find glucose into the urine. If you are diabetic or if you are on some medicines which are causing excretion of glucose in the urine, then you will find glucose in the urine. Otherwise, glucose is reabsorbed by the kidney tubules, so it is not present into the normal urine. The question number 7, how you can live a healthy life with only one kidney? The question is, can you live a normal healthy life with only one kidney? Whether this statement is true or false. If you have only one kidney, can you live a healthy life? And the correct answer is yes, it is possible. Most people with one kidney live healthy and normal life. In other words, one kidney can work as two life as a two. So basically what we need is a half a kidney to live a normal life. 1.5 kidney is given extra to us by a God. So we have a spare kidney. So sometimes patients, need kidney transplant, so their loved ones donate one kidney to them. So donors would not have any problem for their rest of the life. Some people are born with one kidney, but they still live a normal life. So one kidney is sufficient to live a normal life. Medically speaking, which term refers to the kidney? Hepatic, renal, pulmonary, or urinary? Which is the term for kidney in medical language? Answer to this question is renal. So in medical language, it is renal. Which of the Option A, your kidney makes urine. Option B, your kidney removes waste and extra fluid from your blood. Option C, your kidney controls your body's chemical balance. Option D, your kidneys help keep your bones healthy. And option E, your kidneys filter cholesterol. So the correct answer to this is your kidneys filter cholesterol. So this is false. Remaining all statements are true. The kidney produce urine, they remove extra fluid from the body, other chemical balances in the body, and your bones health. Everything is done by the kidney, but it does not remove cholesterol, as I told before that, even in sugar. Question number 10. Does kidney produce vitamin D? It is yes or no. The correct answer is yes. The kidney actually does not produce vitamin D, but kidney helps to produce an active form of vitamin D. So whatever natural vitamin D we take from the food or from the sunlight, it has to be converted into active form, which is the function of a kidney. Question number 11. What is the most common cause of kidney disease? Option A, it is drug abuse, alcohol and smoking. Option B, high blood pressure. Option C, uncontrolled diabetes. And option D, option B and C. So these are the common causes of, what is the most common cause of kidney disease? The answer is B and C. Blood pressure and diabetes. These are the most common. Of the two, diabetes is the most common. But uncontrolled blood pressure is one of the cause, and also it is one of the major cause of progression of the kidney failure. So blood pressure and diabetes are the most two important factors which we need to worry when it is a kidney failure. Question number 12. Which of these over-the-counter medicines can damage the kidney? Naproxen, aspirin, ibuprofen, all of the above. OTC medicines which can cause damage to the kidney. Answer is all of these. So these are the drugs which are called NSAID group of drugs, which if taken regularly in high quantity for long term, can increase your risk of kidney problem. So they should be taken sometimes in a very short period or a very proper indication. It cannot be taken haphazardly without any medical advice. The individuals affected by the obesity have an risk of 83% increased risk of developing chronic kidney disease. Obesity and chronic kidney disease are completely unrelated. 7% increased risk of developing chronic kidney disease. Option D, a 50% increased risk of developing chronic kidney disease. So obesity also has a very important role in your kidney function, and the answer is a significant increased risk of developing chronic kidney disease. So if you have a kidney disease because of any other reasons, the obesity is one of the important factors which can increase your risk of further progression of kidney failure. So BMI is one of the major risk factors for deterioration of the kidney function. Question number 14. A doctor who specializes in kidney disease is called urologist, dermatologist, cardiologist, or a nephrologist. A doctor who specializes in kidney disease. What is it is called? The answer is nephrologist. Urologist also a kidney specialist, but he is a surgeon. He's a surgeon who operates on the kidney diseases, whereas a nephrologist is a physician who works for the kidney diseases. Question number 15. What are the common non-specific symptoms of advanced kidney disease? Option A, swelling in your feet and ankle. Option B, extreme fatigue and tiredness. Option C, dry, itchy skin and muscle cramps. Option D, decreased urination. Option E, shortness of breath. And option F, all of the above. And option G, none of the above. So these are the symptoms. Which are the symptoms of the kidney disease? The correct answer is all of the above. So swelling, fatigue, dry, itchy skin, decreased urine output, shortness of breath, these are the symptoms of the kidney disease. Question number 16. A person can lose up to 90% of the kidney function before experiencing any symptom. So get tested. Is it true or false? Is this statement true? Like if your kidneys are 90% fail and you will not know. Can this happen? Is this statement true or false? Yes, it is true. Sometimes you will have no symptoms till you develop a end-stage kidney disease. So it is a silent killer because there are usually no symptoms, non-specific symptoms until the late stages of the disease, which can happen and which then ultimately land up you into the dialysis or transplant. So better to check periodically. So which are the simple tests to confirm your kidney disease? A urine test for albumin, a blood test for creatinine, a blood pressure measurement, or all of the above? Which are the simple tests? Answer is all of the above. So these are the indicators of the kidney failure, and you should regularly check for this at least yearly in a healthy person and in a diabetic patients or a hypertension patient at least 6 monthly. Kidney disease happening quickly in conditions like dehydration and infections or with exposure to nephrotoxic drugs is known as option A, acute kidney injury, option B, chronic kidney disease. The correct answer is acute kidney injury. So acute kidney injury, it happens when kidney suddenly loses their ability to filter waste from the blood and developing within hours to days. Basically, there are so many reasons when there is acute kidney injury, like dehydration because of diarrhea or some nephrotoxic drug, or because of some infection, or because of some kidney diseases like glomerulonephritis. So these are the conditions where the kidney, when it is fails, it recovers if we treat it. So sometimes you hear that the patient has a creatinine of 10, was on dialysis, but then after treatment, the dialysis stopped. So this happens in acute kidney injury. But this is not the case in chronic kidney disease. So sometimes you get misled that some patients dialysis stop. So I also should try and stop my dialysis. This should not happen. This happens only in acute kidney injury, not in chronic kidney injury. Option 19, question number 19. A progressive condition that developed gradually over months to years and can result in irreversible damage to the kidney is known as glomerulonephritis, acute kidney injury, chronic kidney disease, nephrotic syndrome, which leads to the kidney dysfunction. The creatinine also increases. What is it called? The answer is chronic kidney disease. So it happens gradually and it is a not reversible. Chronic is over after 3 months and it is progressive, not reversible. A genetic disorder that causes many fluid-filled cysts to the cyst into the kidney and that increases to growth in the kidney size. It is called as option A, glomerulonephritis, B, kidney cancer, C, polycystic kidney disease, and option D, end-stage renal disease. A genetic condition which causes multiple cysts in the kidney. The answer is polycystic kidney disease. It is an inherited disorder which can lead to high blood pressure, and in later stages it can lead to kidney failure. Question number 21. What are the common health problems caused by the kidney disease? Option A, high phosphorus and potassium. Option B, heart disease. Option C, bone disease. Option D, all of them. And option E, none of them. These are the common health problems caused by the kidney failure or kidney non-function. The answer is all of them. If kidney is affected, many parts of the body like production of the red blood cell causing anemia, cell decrease leading to anemia, high level of metabolic waste in the blood, which causes metabolic acidosis and so weakness. It can cause damage to the nerve cells and brain, and there will be some fatigue. And because of the continuous high blood pressure and other kidney related issues, there will be heart disease. Question 22. Is anemia linked to the kidney failure? Yes or no? The answer is yes. Kidney helps to maintain hemoglobin level. Basically, kidney produces a hormone called erythropoietin, which is necessary for the blood production. So once the erythropoietin signals the bone marrow, then only the bone marrow can produce red blood cells. And so it is one of the most important organ for the blood production. Question number 23. What are the other important lifestyle changes to protect kidneys? Which can protect your kidneys by good healthy lifestyle. Option A, regular exercise. Option B, limit alcohol. Option C, read package labels. Option D, control phosphorus intake. Option E, take adequate fluid. And option F, all of the above. So these are the lifestyle changes which can protect the kidney. Which option is right? The correct answer is all of the above. So these are the important habits which we should have and which will protect not only the kidneys but overall our health. So these are the essential habits which we should continue. If you have a decreased kidney function, you should monitor which of the things in the diet. Option A, protein. Option B, salt. Option C, food dyes. Option D, A and B. These are the things which to be avoided in patients who are having kidney disease. Option A and B, protein intake and salt intake. People who have decreased function of their kidneys may need to monitor their protein and protein in the diet. Salt also increases the blood pressure, so it is also very important that we restrict the salt intake. Question number 25. A kidney-friendly diet does not include food low in fat, salt, and animal meat, adequate water intake, processed food and frozen meals, soda and cola. Option A and B, option C and D. A kidney-friendly diet does not include. So we have to give the does not. So it is a false. The correct answer is option C and D. People with kidney disease need to follow a diet low in sodium, low in protein and potassium and phosphorus. So people who eat a lot of processed food have a 24% higher risk of kidney disease. Basically, processing would require a lot of salt. Otherwise, the preservation is not possible. Question 26. Fruits to be avoided or limited in patients who have a kidney disease. Apple, berries, papaya, pineapple, and banana. Answer is banana. Banana is a rich source of potassium and it need to be limited. Question number 27. What glomerular filtration rate is kidney failure? Like when we see many laboratory tests, we see eGFR or GFR. So when we call that the kidney has failed now, at what level of GFR? It is above 90, above 60, below 15, or above 45. The answer is below 15. When GFR falls below 50, GFR test is used to check how well is the kidney working. A GFR of 90 or higher is normal, and a below 15 is suggest a kidney failure. What are the latest treatment for the kidney diseases? Lifestyle changes and healthy diet, medication, dialysis, kidney transplant, all of the above. When you have a kidney which is failing, what are the things which will help in treatment? All of the above. So initial stages of kidney failure, lifestyle changes, medications would help. In terminal stages, when the kidney fails completely and when your GFR falls below 15, or when you are CKD stage 5, the dialysis or kidney transplant is the treatment. What is the procedure of artificial removal of the waste from the body? So when the kidney fails, how do you remove the waste from the body if the kidney is not functioning? Is it dialysis? It is AV fistula, it is transplant or catheterization, artificially removing the waste? The answer is dialysis. Which treatment option is better to treat end-stage kidney failure? Dialysis or kidney transplant? The answer is kidney transplant. So in majority of the cases, transplant is a better option. It is not the only option, but it is in young patients and patients who are fit for transplant. Kidney transplant is a treatment of choice for many people with end-stage kidney disease. It is a successful kidney transplant can improve your quality of life and reduce your risk of any other life-threatening complication. Thank you. I'm sure you must have liked it, and I will be happy to see all the answers in the chat box, and thank you so much.
Thank you, Sonal ma'am. That was really nice question, a lot for the patients and the other audience who were there to take up. And also, there were a lot of exciting people who wanted some prize for that. So we have just appreciated them.
No,
So
actually, Ranjani, what you can do is now these answers are captured, no? So whoever
yes,
has answered maximum correct answers, so I
yeah.
mean, we will get to know. So we can give some, what do you call some prizes for them
Okay,
in subsequent what do you call meetings.
okay. So we
Okay,
have
and
writing.
if I mean, we can identify them for which state they are, and we can the state the chapters they can honor them in their own local meetings. That also can.
Oh,
We'll
so
definitely try
the
to award recognize those who have answered actively,
Okay.
and not just the only the for winners who has answered also. I think we should able to recognize them. No, I just request no when all of the participant don't be
Hello,
disheartened. We will try
Swarnalata.
to do something for them.
Right.
I think all the audience, you should stay hooked to all the women in nephrology activities because you will get to learn
Hello,
more
I
and
am
more.
Dr. Tamilarazi from Chennai. The questions are all very nice questions, and the way in which you discuss very nice. Congratulations to you. Thank you.
Madam, we are halfway through. Another program is there.
Please, yeah, please be with us. Let us move on to the next topic, which is about organ donation. And we call upon Dr. Swanlata ma'am to give the talk. And the moderator would be Dr. Monali Sahu. So over to Dr. Monali Sahu.
Yeah, thank you very much. So I welcome Swarnalata Guditi ma'am, senior nephrologist. And madam, let us start our discussion with the organ donation scenario in India. As per WHO, it is only 0.01% organs being donated after death. So what is your take on this? Why you feel is the organ donation rate is so low in India?
Yeah, thank you, Mona Lisa. And first of all, I'd like to appreciate the Win India, particularly the Win Tamil Nadu, the Secretary Dr. Ranjini for organizing such a beautiful, program, for series of programs, I can say, for this World Kidney Day. And today only we have kickstarted this program, and we have started with an advocacy program for the patients so that it is more knowledgeable and they are benefited. And I believe that there is a lot of attendance is there. I can see there are more than 70, some point it has crossed 70 also. So and believe patients are being benefited out of the program. And I really assure that our advocacy committee is very active, and we will try to involve payment by patients who can be support our organization and thereby benefit our patients, kidney patients by and large. So I think with this, we'll go on to the questions. The first question was, I think, why our donation rate is very less. So if you look at, I mean, ours is one of the, I think now it is the one of the maximum population in the among all the countries. But despite that, our donation rate is very less. So there, as has been emphasized by the previous speakers, there are two types of organ donations. One is live and the deceased donor. So our predominantly, if we compare our donation rate to the West, so ours is basically live related. So a majority of the patients, more than 80 to 85% of the all organ donations are from the live related. The deceased donor is very, very less. It is less than 0.1 million million per population. So as contrast to a Western, where maximum is reported to be in the Spain, where it is more than around 50 per million population, and in the US it's somewhere around 40 million per million population. So our India has been lagging very behind, and it is, I mean, hardly touching 1 per million population. But having said that, it is little diverse across the India. Few of these states, southern states, are doing very good, particularly Telangana, the Tamil Nadu, Karnataka, and Maharashtra, and Gujarat, and these states have been doing good, and I mean the range, it ranges from 3 to 5 million per million population. So it basically depends upon because the brain declaration awareness among the doctors, so the medical fraternity itself is very less. And as you can see, the infrastructure at a peripheral level is very low, so that these patients, the brain death patients, are often missed. And there's a lot of awareness is required amongst the medical fraternity as well as the society. Even if these are identified, the brain deaths are identified, and the doctors try to declare, and the acceptance among the public is very less, though it is increasing slowly over a period of years. But I think there's long way to go forward and increase the donation rate. So this change in the donation rate is you're able to see gradually, appreciate gradually, particularly in the few of the state, where we can see 30 to 40% is deceased donation and 60% is the live donation. So with increasing the pool of the paired kidney donation and the ABO incompatible, I think we can increase the transplantation, and simultaneously we concentrate on the donation after brain death. I think we can actually increase the donation rate. And coming to the next, that is the donation after cardiac death, what's called as DCD. DCD, if you look at the Western countries, they are actually moving away from the DBT towards the DCD, donation after cardiac death. Again, there is a lot of challenge in India, right from the legalities, particularly uh, when to take the consent, and when to stop the organ and the patient resuscitation measure. There is what is called as a cold ischemic, warm ischemic time. So all these have to be defined before we start accepting the donation after cardiac death. And a lot of logistics are required, a lot of infrastructure is required at the hospital end to for particularly with respect to availability of the ECMO and other infrastructure, before we can at least think of starting a donation after cardiac death.
Yes, ma'am.
Over to you.
And there is one more thing. What we are noticing is gender disparity. Proportionately, very less female patients are being transplanted, and proportionately, very large number of females are donating. So,
Yeah,
what
I
is your
totally
take on
agree
this?
with you. The gender disparity is not just in India. I think the gender disparity is there all across the world. You see most of the females being the donor, and if you come to the recipients, it's the male who are the recipients. And then most of the females also, if you look at it, is either the mother or the wife donating. And basically, it is the access to the kidney care. They're illiterate, and they're not, females are not, if they are become a kidney patients, they're not given the importance, and they're not considered for, particularly when they realize it's a long-term process. So usually they're not given that option of going to a dialysis or for the transplantation. And particularly if a female becomes sick, or the entire family is dependent on that. So that's the reason, again, they are not given, the particularly chronic, the treatment or the transplantation options. The other way around, when the male becomes sick, the female has, particularly we see in our day-to-day practices, females are so emotionally, bond to them, and they do, not just a household activity, they try to earn also and then take care of the husbands. So we have a lot of patients who have been there for 20 years. The male persons have, had a kidney disease. The females, they've never been exposed to anything, but they still go out, they try to earn. And I still remember one of the, wife who got this job in a ESI, and she could maintain all the healthcare services under the ESI category. She's earning for the family member, and is trying to stabilize financially, emotionally, and building the support system. So that is a strong attitude of the female. So that disparity is still there, in India, and I mean, in fact, you can see that disparity across the world, and we are still trying to reach that gender disparity. And of course, that is one of the main agenda of the Women in Nephrology, to address this disparity, as well as, I mean, as well in the particularly with respect to the healthcare, in the access to the healthcare for the women patients, kidney patients.
Yes, ma'am. So well said, and we really need to work for this. And another point is that transplantation is taken by patients as a game changer. And but would you like to tell our patients what is the need they need to take, what is the care, or what are the drugs, for how long they need to take,
Yes.
or is it that it is a game changer and everything is done?
Yeah,
Yeah.
definitely it's a game changer, and I think this is something like a rebirth. So I can say transplant is a rebirth for all kidney patients. In fact, this point was emphasized by the previous speakers in the panelists and our panelists also, that transplantation, like, it actually, they'll have a near normalcy of life. And with transplantation, the GFR, at least it increases to about, something like 60 to 70%. But with any modality of renal replacement therapy, whether it is hemodialysis or the CAPD, with whatever increase in the dosage, if you increase the dose, by maximum, the GFR we can replace is 10 to 15% only. Beyond that, we cannot achieve. But with transplantation, we can achieve a GFR, which is the functioning unit of the kidney. So we can achieve almost 50 to 60 ml per minute of GFR. And not just the filtration or the GFR, we can also replace the other functions of the kidney, like the bone health, the anemia, hypertension, fluid management. Everything is regained. So that's the reason why the patients have a normal quality of life. But only thing here challenge is they have to be on immunosuppressive medications. That is, they have to use these drugs for lifelong. I mean, even if they stop these medication even for a day, they might, get a rejections. So that is only a challenge, that they need to continue the medications for the lifelong. But once initially they start using these drugs, they get used to it over a period of time, and they have the knowledge that, these have to be taken at what dosage and what time. So they will try to, use that, and that mindset should be there. The other thing is, because these are immunosuppressive medication, the immunity will come down, and they are more exposed, or they are more prone for the infection. So they have to maintain the hygiene, particularly with respect to their food. What the food they are eating, they should be like healthy, and they should be fresh, and they should not be eating outside in unhygienic areas. And the water they should be drinking should be pure, and they should not move on into crowded places, and where there is chances of, getting the respiratory infections. And they should maintain their health. They should have, I mean, they should be exercising regularly, take hygienic, and healthy food. So these basic health should they, I mean, hygiene should be taken care of. If these two things, the health, in terms of the hygiene, and as well as the medication, if these two are taken proper care, I think they'll have a normal quality of life. And initial few months, particular 6 months, is a very crucial time, because they require larger doses of medication. They are more prone for infection, and there is a high chance of rejection. Once they cross 6 months to 1 year, their medications comes down to a minimal dosage, so they can actually have a absolute normal life. So I think, as you said, definitely it's a game changer, and it is something like a new birth for them.
Yes,
Yes,
ma'am.
over to you, Mona Lisa.
Yes, ma'am. So another thing is, now we are doing lot of transplants across ABO blood groups or HLA mismatching. Um, people we are seeing that they have some fear about it, or they feel whether how long they will survive. So please guide about that.
Yeah, yeah. So
Yeah.
initially we used to have the ABO compatibility, but now the science has advanced, and we have a newer medication, more advanced and effective drugs available. So across the transplantation across the group is also possible. That is called as the ABO incompatible transplantation. But then we should do an extra test whether they are compatible, or they are able to accept that incompatibility or not, in terms of the antibody titers. We look at the antibody titers. If antibody titers are at a lower levels, so transplantation can be done. But however, they require certain immunosuppression, which is more than the regular immunosuppression. So because we are giving this extra immunosuppression or extra dialysis called extra, plasmapheresis, the special dialysis. So these medications and this dialysis has to be done at least 2 weeks to 4 weeks before transplantation. They have to be prepared extra. So that is the reason why extra precaution has to be taken. But once the transplantation is done and they overcome 2 to 4 weeks post-transplantation, after that they are as good as the ABO compatible transplantation. But only thing is they have to make sure that they are approaching the doctor and they are explained about the consequences, and they fall in the what you call acceptable range of antibodies. And if they can take an extra care in terms of infections and then medications, they can be easy transplantation can easily be done. And there are a lot of hospitals and lot of states they are doing incompatible with a very good success rates. This is one of the measure to increase the transplantation. If they have, within the family members, if they have a healthy donor, but only, blood group incompatible, so you can go for this option.
Yes, ma'am. Just quick two last questions. What is the organ allocation system followed?
Yeah, so organ allocation system again, basically they have broader rules. Basic or now our country is diverse. India has different states, they follow different allocation policies. So and then now when India is moving towards one nation and one organ allocation policy. But having said that, because different states are at different levels. For example, southern states are doing very good. And even if you look at the western the states, for example, Maharashtra and then Gujarat, they are doing very good. And down south, we have Tamil Nadu, Telangana, Karnataka, they are good. So we have evolved and we have a different allocation policy. It can be as simple as just the registration. Once the patient get registration, they will be their time the starts their seniority timing they starts in the list. On the other hand, we have a systems where multiple factors are taken into consideration, not just the registration, time of registration, but time on dialysis. The scientific reason for this being patients who are longer on dialysis, the chances of survival or the chances of having a quality of life on dialysis becomes meager, so start decreasing. So the patient on dialysis should be given a priority. And then again, the patients, when pediatric patients who are young, so because their quality of life would be good and their longevity of life also will be more than the elderly, they are given preference. And in some states, they also consider the fistula, because fistula is the lifeline for these patients. If they have fistula failure, so they are given a preference. They have given they get a score points. So there are some other few parameters, like the patient was a donor previously, they have donated organ to their own family member, and now they have landed up in kidney failure. So they are given certain priority, certain score points. So there are different systems, right from just simple system to registration to multiple parameters like duration of dialysis, the access failure, previous kidney donor, and the pediatric patients. These are all given a score system. So the states can discuss depending upon their committee recommendations. They are following a different allocation guidelines. And
Yes, ma'am.
to have advanced allocation guidelines, we do have HLA match. I don't think in India any of these states are following HLA matching. It is only done in Western countries like USA and Europe. So I think there are few
Yes.
more questions in chat box.
Dr. speaking. See, this long duration before transplant is better than short duration. Which you prefer?
Madam, I couldn't get you, madam.
No, this duration of dialysis longer or shorter prior to transplant. Which one you prefer?
Longer duration. They are given a preference, madam.
Oh.
I mean, can we take the questions in the chat box, because few of the people they have posted. I think it is better on our part to answer these questions. I think one question was an incompatibility which I have answered, and I think that Bhagwan Reddy has asked about he is a 12 years post transplant and he would like to be a part of this advocacy. Definitely, we will try to involve you in future programs. And of course, the kidney pair donation he has asked. I think the few of the states are following these kidney pair donation, particularly with respect to Gujarat. But I think when one of the disease donor transplantation programs where it is successful, like Tamil Nadu and Telangana, can start this program, particularly with respect to Telangana. I think once the act is amended in Telangana, we will start using these the kidney pair donation as well. And other question.
Okay, thank you. Thank you.
Ma'am, the one particular pressing concern what Bhagwan Reddy was asking was why aren't hospitals collaborating for swab transplant similar to cadaveric organ donations through Jeevan Dan?
Yeah. I mean, I think that is the next step. Once we have a successful decision transplantation program, particularly in our state, the main challenge is we did not adapt the amendments, the latest amendments of 2014, which allows the kidney pair donation or the pair kidney donation. So if that is adopted in Telangana, I think we can start using that.
Okay.
And other states can answer if what is happening in at their states.
So in Maharashtra, we have the sorter registry, which is happening very well. It is used across the country as well. So we recently did, that one between Hyderabad and Maharashtra, and now we are having a 6-way swap happening within Maharashtra in different cities. One from Pune, one from Kolhapur, two from Mumbai, and one from interior of Maharashtra. So it is happening. It's just that the doctors have to collaborate and get the exchange done, and the swaps are happening in the respective states and in the respective hospitals. So the patient need not travel to this center, the donors travel to the respective transplant centers. It's just that sometimes public private creates an issue, but most of the times it is settled. The only thing I think is a hitch is that all the states in the country have to be at par with the laws. That's the only thing which causes a little bit of a delay in the swab transplants. Otherwise, it goes pretty quick. Like Maharashtra is a very well oiled machine. Within a week or two, we get permissions from the government and from the local hospitals.
Also, we have swap registry, so it will be
Yes.
it will be helpful for other states also
So
to
like
follow
we
up.
have sorter with us, so we have it nationally and it's free of charge. People can simply register. Their doctors can send details to us and we can register it. We are not charging anything as of now because it's a service for the patients. And then the transplants can be taken ahead once everything is done. And this is usually swaps. I have made this registry mainly for the people who are cross match positive or who have any issues, like there are patients where the own donors cannot give the patients for various reasons, like we have medical diseases like IgA nephropathy, you have some genetic diseases. So these registries work for that and scientifically made to give you a proper match to make your immunological risk lower than what it would be if your own donor gives.
So there is another question. What all do we consider before taking cadaver kidney, like age, antibodies, creatinine, whether diabetic, etc.? So actually, before taking the patient for a disease donation, accepting the kidney organs for from a disease donation, we look at all the parameters, including the history like hypertension, diabetes, and any other metabolic disorder, the liver disease. And at the time of donation, we look at all the biochemical parameters, include the infection, hepatitis B, hepatitis, creatinine, and FT. All are considered. I mean, antibodies basically look at the recipient. We also match like, donor and recipient. We try to, do a cross match, and that is accepting. Then we can take the organ. Diabetes is not a contraindication. Patient is a recent onset diabetes, and the kidney function is good. There is no proteinuria. We can actually take a hypertension diabetes patients also. Even age is not a criteria. So recently what we have seen is patients, the elderly patients with 60 plus, around 70 also, they are donating the kidney. If their kidney functioning is very good and they don't have hypertension, diabetes, so we can take the organ. And if you have any doubt, there is an option for the biopsy. That's what is called as a frozen biopsy. So we can take a biopsy, we can take a bit of kidney, we can examine, and a report will be given within half an hour. If the organ is good, the biopsy is good, we can take these organs. So it is not absolute contraindication. Even hypertension, diabetes, in the elderly age, they can be considered for organ donation, but we look at the functioning of the organ before taking. Okay, I think your answer is
it's time now for us to wind up. Thank you very much, Dr. Swarnalata madam. And now we are awaiting a very interesting movie clip by Dr. Shruti Tapiawala madam. Over to you, ma'am.
Thank you. Thank you.
So we are now going to, for the audience, you all have been wonderful. We have taken you through what is end-stage kidney disease, what are the options which can be looked into for a patient who is suffering from kidney failure, right from living donation to waiting on a cadaver list. Now we are going to show you a movie which is going to take you behind the scenes of an organ donation. So for example, when you receive a call from the hospital that your patient is on the list and you are going to receive an organ, would you like to come? We would like to show you a movie so that you can get an actual feel of what the hospital, the doctors go through when they are calling you for organ transplant, when you're waiting on a dead organ donor list. This will give you the understanding of what goes behind before you get a call and after you get a call till your transplant happens. So Saurabh ji, if you can start the movie.
Yes.
And this movie has been made by Zonal Transplant Coordination Committee in conjunction with NOTO. So this is how the entire country follows the system. So you will have a good understanding of the system which the country follows. Saurabh ji, full screen and thoda volume.
Yes, ma'am.
हर साल हजारों की संख्या में जरूरतमंद लोगों को अंगदान की वजह से नया जीवन प्राप्त होता है। यह संभव होता है प्रत्यारोपण या ट्रांसप्लांट की प्रक्रिया द्वारा, जिसमें हार्ट, किडनीज, लंग्स, लिवर, पैनक्रियास, इंटेस्टाइन्स, टिश्यूज एंड कॉर्नियास जैसे अंगों का ट्रांसप्लांट संभव होता है। भारत में ऑर्गन रेसिपिएंट्स के बदले ऑर्गन डोनर्स की मात्रा बहुत ही कम थी। सभी प्रकार की तकनीकी सुविधा और शासकीय संस्थाओं के होने के बाद भी ऑर्गन डोनेशन की संख्या में परिवर्तन नहीं आ पा रहा था। नागरिकों में अंगदान के बारे में जागरूकता की कमी, अंगदान से जुड़े अंधविश्वास और भ्रांतियों के चलते ब्रेन डेड मरीजों के परिचारकों की असहमति और उचित शिक्षा के अभाव के कारण महीनों तक नेशनल वेटिंग लिस्ट में अपनी बारी का इंतजार करते हुए कितने ही आशावादी मरीजों ने अपनी जान खो दी। डिमांड और सप्लाई के गैप के चलते ऑर्गन ट्रेडिंग या कमजोर लोगों के ऑर्गन्स का व्यावसायिक शोषण होने लगा, जिसे कंट्रोल करने के लिए मिनिस्ट्री ऑफ हेल्थ एंड फैमिली वेलफेयर ने नेशनल, रीजनल एंड स्टेट ऑर्गन एंड टिश्यू ट्रांसप्लांट ऑर्गेनाइजेशन का निर्माण किया, जिन्हें हम नोटो, रोटो एवं सोटो के नाम से भी जानते हैं।
NOTO was set up to provide national oversight of organ donation and transplantation activities in the country as per the WHO guidelines. As the National Human Organ and Tissue Removal and Storage Network does the job of the National Registry, both of these being mandated by the 2011 amendment of the Transplantation of Human Organs Act 1994. Formulation of guidelines, protocols, allocation policies and SOPs are a part of the function of NOTO. The donor families are felicitated every year and awarded during the Indian Organ Donation Day celebrated by NOTO
I truly thank the Roto West for taking this initiative to spread the awareness about organ donation in the country. For India is the world leader in living donor transplants, while it is way behind in disease donor transplants. And we need to work together to achieve a robust diseased organ donation rate in the country.
The Regional and State Organ and Tissue Transplant Organization was formed in February 2017 at the St. G.S. Medical College and KM Hospital, Mumbai. This organization has been mandated and defined as per the amended Transplantation Act and the rules of 2014. As Western Region Roto, we cover the states of Maharashtra, Goa, Gujarat, Chhattisgarh, Madhya Pradesh, Nagar Haveli and Diu and Daman. The main functions of Roto are monitoring and surveillance of all the transplant activities in the region, allocation of organs when they are exchanged in between the states, creating awareness in the general public, creating awareness activities and training activities for the personnel involved in organ donation. The other functions of the Roto are mainly establishment of a registry for organ transplantation, conducting of training programs, intersectoral programs and workshops for the region, dissemination of information for the region, and establishment of SOTOs in other regions and providing them technical support.
SOTO यानी कि स्टेट ऑर्गन एंड टिश्यू ट्रांसप्लांट ऑर्गेनाइजेशन। हर स्टेट में एक SOTO है जो उस राज्य के सारे ऑर्गन ट्रांसप्लांट रिलेटेड गतिविधियों के लिए रिस्पॉन्सिबल होती है। यह ऑर्गेनाइजेशन नोटो और रोटो के अंडर में काम करती है और यह पूरे स्टेट यानी कि महाराष्ट्र राज्य के लिए सारे ऑर्गन ट्रांसप्लांट रिलेटेड एक्टिविटीज के लिए रिस्पॉन्सिबल है। जैसे महाराष्ट्र स्टेट है तो महाराष्ट्र स्टेट में सोटो जो है वो KEM में लोकेटेड है। इसका काम क्या है? पहला काम यह है कि जितने भी ZTCCs हैं उनके साथ मिलके ऑर्गन डोनेशन, ऑर्गन ट्रांसप्लांट, इससे रिलेटेड अवेयरनेस फैलाना। इसके अलावा जो पेशेंट्स हैं जिनको ट्रांसप्लांट की ज़रूरत है उन पेशेंट्स की लिस्ट को मेंटेन करना, ZTCC को हेल्प करना और ऑर्गन रजिस्ट्रेशन के लिए, ट्रांसप्लांट के रजिस्ट्रेशन के लिए, और सारे ZTCCs की लिस्ट को मिला के एक कॉमन लिस्ट बनाना, ये भी सोटो की जवाबदारी होती है। इसके अलावा जब कोई ऑर्गन आइडेंटिफाई होता है, कोई डोनेट करता है, तो वो ऑर्गन किसको जाएगा, वह ऑर्गन किस पेशेंट को मिलेगा, ये भी सोटो की जवाबदारी होती है विद इन द स्टेट। इसके अलावा मान लीजिए कोई ऐसा ऑर्गन है जिसके लिए पूरे स्टेट में कोई रेसिपिएंट नहीं है, तो वह ऑर्गन राज्य के बाहर रोटो में जाएगा, ये रोटो को नोटिफाई करना भी सोटो की जवाबदारी होती है। इसके अलावा जो भी ट्रांसप्लांट से रिलेटेड लोग हैं, जो भी इंटरैक्ट करते हैं, जैसे कि सोशल वर्कर्स, कोऑर्डिनेटर्स या रिट्रीवल सर्जन्स, इनको लगातार ट्रेनिंग देना, इनके स्किल्स को इम्प्रूव करना और ये अपना काम बेहतर से बेहतर कर सकें, इसके लिए लगातार ट्रेनिंग देना, ये भी सोटो की जवाबदारी होती है। और मोस्ट इम्पॉर्टेंटली जो भी राज्य सरकार, स्टेट गवर्नमेंट पॉलिसीज़ बनाती है ऑर्गन ट्रांसप्लांट को लेके, चाहे वो एलोकेशन के लिए हो, चाहे वो डोनेशन के लिए हो या डिस्ट्रीब्यूशन के लिए हो, यह सब में एडवाइजरी रोल, इम्प्लीमेंटेशन वाला रोल सोटो का होता है। तो अगर आप देखें तो ग्राउंड लेवल से लेकर के रीजन के बीच में ये ऑर्गन डोनेशन से रिलेटेड सारी गतिविधियों के लिए सोटो एक बहुत इंपॉर्टेंट कड़ी होती है, जो हर लेवल पे ऑर्गन डिस्ट्रीब्यूशन, एलोकेशन, आइडेंटिफिकेशन के लिए रिस्पॉन्सिबल होती है।
मेडिकल साइंसेज में होने वाले आविष्कारों में ट्रांसप्लांट एक अभूतपूर्व शोध है। महाराष्ट्र में ऑर्गन डोनेशन एंड एलोकेशन का संचालन करता है जोनल ट्रांसप्लांट कोऑर्डिनेशन सेंटर।
In 1994, Indian Parliament passed the Transplantation of Human Organs Act. Maharashtra was the first state to adopt this act in 1995. When the act was passed, it was not known how to implement it. In February 1995, Government of Maharashtra, under Director of Medical Education and Director of Health Services, appointed an expert committee It was late Dr. V.N. Acharya and myself from KM Hospital, Dr. Dawar from JJ Hospital, and Dr. Vatsala Trivedi from Sayan Hospital. Expert committee was given the task to go about how to create awareness about the organ donation, organ transplantations, and also to give the guidelines for how to implement the different provisions of the Act in the state of Maharashtra. The main purpose was to implement the part which is related to the diseased organ donation and retrieval of the organs from the deceased donors for transplantation purpose. In July 1999, the government of Maharashtra created two bodies, one at the state level, it is called Maharashtra Confederation for Organ Transplantation, and second are the JTCCs at the level of the city and the revenue division. There were 4 JTCCs created. The Mumbai was the first to come in existence on 31st March 2000. This was followed by Pune JTCC and then the Aurangabad and Nagpur JTCC. So Mumbai JTCC covers the Mumbai division, which consists of Mumbai, Thane, Navi Mumbai. The Pune JTCC covers the Pune and Nashik divisions. Aurangabad JTCC covers the Aurangabad division, while the Nagpur JTCC covers the Nagpur and Amravati division. JTCC was created by the government as an independent body to look after the organ distribution, and for that to maintain the waiting list of all the recipients in their zone. Once the JTCC was created, for their smooth functioning, each JTCC has been divided into 3-layer administrative system. The first layer is Executive Council. The purpose of this Executive Committee is to look after the day-to-day functioning of the JTCC. Over the Executive Council is the Governing Council. Governing Council meets every 3 months and ratifies the decisions taken by the Executive Council. Over the Governing Council is the General Body, and this consists of all the type of members of the JTCC, and this meets once a year when the annual appraisal of the JTCC function is done. All these office bearers of the Executive Committee are honoraries. They are not paid by either the government or by the JTCC. So they function on the voluntary basis.
ह्यूमन ऑर्गन ट्रांसप्लांट एक्ट भारत में 1994 में पारित हुआ। 1995 में महाराष्ट्र ने और गोवा में इसे सर्वप्रथम अडॉप्ट किया गया है। ये एक्ट के अंदर वहाँ पे 3 कमिटीज़ बहुत ही महत्वपूर्ण है। जो सबसे पहले कमेटी है वो है अप्रोप्रिएट अथॉरिटी कमेटी।
डायरेक्टर हेल्थ सर्विसेज इसके स्टेट अप्रोप्रिएट अथॉरिटी है। डायरेक्टर हेल्थ सर्विसेज का काम है कि राज्य में जितने भी हॉस्पिटल्स ट्रांसप्लांट करना चाहते हैं उस हॉस्पिटल्स का रजिस्ट्रेशन करें। उस हॉस्पिटल में जो डॉक्टर्स काम करना चाहते हैं, ऑर्गन ट्रांसप्लांट करना चाहते हैं, उनका रजिस्ट्रेशन करें। ये हॉस्पिटल्स और डॉक्टर्स एज पर एक्ट इम्प्लीमेंटेशन कर रहे हैं कि नहीं, इसका ऑब्जर्वेशन करें। अगर नहीं किए जाते होंगे तो उस पर जो भी प्यूनिटिव एक्शन एज पर एक्ट है वो भी एक्शन उन्होंने उसमें लेना है।
दूसरी जो समिति है वो राज्य सलाहकार समिति है, स्टेट एडवाइजरी कमेटी है।
स्टेट अप्रोप्रिएट अथॉरिटी को एडवाइज करने के लिए स्टेट एडवाइजरी बोर्ड बनाई गई है। इस एडवाइजरी कमेटी के चेयरमैन प्रिंसिपल सेक्रेटरी पब्लिक हेल्थ रहते हैं। उसके बहुत सारे मेंबर्स भी हैं, उसमें लीगल के लोग हैं, डॉक्टर्स हैं। तो ये सब लोग मिलके अगर एक्ट में कुछ इश्यूज आए, इम्प्लीमेंटेशन में कुछ प्रॉब्लम आ जाए या आगे क्या प्लानिंग करना है, ज़्यादा से ज़्यादा ऑर्गन ट्रांसप्लांट हो, ज़्यादा से ज़्यादा अच्छी तरह से एक्ट इम्प्लीमेंट हो, उसके लिए ये एडवाइजरी कमेटी एडवाइस करती है।
तीसरी जो महत्वपूर्ण कमेटी है वो है अथॉराइजेशन कमेटी। डायरेक्टोरेट ऑफ मेडिकल एजुकेशन के अंडर ये समिति रहती है। अथॉराइजेशन कमेटी का मेन उद्देश्य है कि नॉन रिलेटेड जो ट्रांसप्लांट रहते हैं, जो ब्लड रिलेटेड नहीं है, उनको परमिशन देना, और जो फॉरेन नेशनल्स रहते हैं उनको भी इस कमेटी के तहत परमिशन दिया जाता है।
नमस्ते, मैं डॉक्टर तात्याराव लहाने हूँ। मैं मेडिकल एजुकेशन का संचालक हूँ। हमारे अंडर स्टेट ऑर्गन का जो कमिटी होता है, ऑथराइजेशन कमिटी है, वो है। हम जो है लोगों को जब भी ऑर्गन लगता है तो अनरिलेटेड डोनेशन बोल के आता है, इमरजेंसी डोनेशन बोल के आता है, या कहीं लोगों को बाहर जाके दूसरे स्टेट में जाके करना पड़ता है। ऐसे वक्त हम उनको नो ऑब्जेक्शन देने का काम करते हैं। ये हमारा कमिटी इमरजेंसी में मिलता है और इमीडिएटली परमिशन देता रहता है, जो लेजिटिमेट डोनेशंस है उसको करता रहता है।
किसी भी हॉस्पिटल को ह्यूमन ऑर्गन ट्रांसप्लांट के अंदर रजिस्ट्रेशन करने के लिए हॉस्पिटल के अथॉरिटी ने फॉर्म नंबर 12 भर के स्टेट अप्रोप्रिएट अथॉरिटी को अप्लाई करना चाहिए। स्टेट अप्रोप्रिएट अथॉरिटी फॉर्म नंबर 12 और उसके डॉक्यूमेंट मिलने के बाद डॉक्यूमेंट स्क्रूटिनी करते हैं और डॉक्यूमेंट स्क्रूटिनी करने के बाद एक्सपर्ट कमेटी के द्वारा उस हॉस्पिटल का इंस्पेक्शन करते हैं। इंस्पेक्शन करने के बाद अगर उनके डॉक्यूमेंट और हॉस्पिटल की फैसिलिटी एक्ट के अनुसार बराबर है तो हॉस्पिटल को रजिस्ट्रेशन और लाइसेंस दिया जाता है।
अब महाराष्ट्र के अंदर हमने 110 अस्पतालों को रजिस्ट्रेशन किया हुआ है। उसमें से किडनी के लिए हमारे 106 रुग्णालय है, लीवर के लिए 41 रुग्णालय है, हार्ट के लिए 24, लंग के लिए हमारे 9 है, पेनक्रियास के लिए हमारे 11 रुग्णालय पंजीकरण हुए हैं। इंटेस्टाइन, बोवेल, ऐसे जो ऑर्गन छोटे मोटे हैं इनके लिए हमने 4 अस्पताल पंजीकरण किए हुए हैं। टिश्यू डोनेशन, इनके लिए हमने ऑलमोस्ट 9 अस्पतालों को पंजीकरण किया हुआ है। हाथ के लिए हमने 3 लोगों को रजिस्ट्रेशन दिया है। यूट्रस के लिए हमने 2 अस्पतालों को रजिस्ट्रेशन दिया है। 67 ऐसे जो हमारे अस्पताल है वहाँ पे ऑर्गन ट्रांसप्लांट नहीं होता है, लेकिन वहाँ पे रिट्राइव किया जाता है।
जोनल ट्रांसप्लांट कोऑर्डिनेशन सेंटर मुंबई एक संस्था है जो जब ऑर्गन अवेलेबल होते हैं तो उसको कैसे ऑर्गन रिसिपिएंट्स को डिस्ट्रीब्यूट करे, ये उसका काम है। तो सबसे पहले ये ऑर्गेनाइजेशन जो लोगों को ऑर्गन्स की ज़रूरत है उसका एक कंप्यूटराइज्ड वेटिंग लिस्ट मेंटेन करता है। मुंबई में 35 हॉस्पिटल है जो रजिस्टर्ड ट्रांसप्लांट सेंटर्स है। उस हॉस्पिटल के द्वारा रजिस्ट्रेशन ZTCC के साथ किया जाता है और सभी पेशेंट का ब्लड ग्रुप के हिसाब से अलग अलग ऑर्गन्स का एक अलग लिस्ट मेंटेन किया जाता है। अब अगर किसी हॉस्पिटल में कोई ब्रेन डेड पेशेंट है तो उस हॉस्पिटल का ट्रांसप्लांट कोऑर्डिनेटर ZTCC के ट्रांसप्लांट कोऑर्डिनेटर को बताएगा कि उनके अस्पताल में एक ब्रेन डेड पेशेंट है और उस पेशेंट के बारे में पूरी इन्फॉर्मेशन ZTCC कोऑर्डिनेटर को दी जाती है। ये इन्फॉर्मेशन फिर सब रजिस्टर्ड ट्रांसप्लांट सेंटर्स को दी जाती है। जब ब्रेन डेथ होता है तो पहली किडनी जिस हॉस्पिटल में डोनर रहता है वहाँ जाती है। लीवर पहले सुपर अर्जेंट रिसिपिएंट को दिया जाता है। अगर कोई सुपर अर्जेंट रिसिपिएंट वेटिंग में न हो तो उसी अस्पताल में लीवर, हार्ट और लंग्स जाते हैं। दूसरी किडनी सिटी के पूल में जाती है। उसका डिस्ट्रीब्यूशन कैसे होता है तो ZTCC जो वेटिंग लिस्ट मेंटेन करती है उसमें हर एक वेटिंग लिस्ट पेशेंट को स्कोर दिया जाता है। ये स्कोर दिया जाता है सर्टेन क्राइटेरिया के हिसाब से। तो स्कोरिंग सिस्टम के हिसाब से उस पेशेंट को किडनी मिलती है जिसका सबसे ज़्यादा स्कोर है।
महाराष्ट्र को गए 3 सालों से विविध एक्टिविटीज़ के अंदर हमको सबसे ज़्यादा ऑर्गन डोनेशन करने के लिए हमको प्राइज़ मिला था।
डोनेट द ऑर्गन एंड गिव द लाइफ टू द नीडी पर्सन। मेरा एग्जाम्पल आप लीजिए, मेरे मदर ने मुझे 1995 में किडनी दिया है उसके ऊपर मैं ये काम कर रहा हूँ और आज तक मैंने कम से कम 1.5 लाख ऑपरेशन किए हैं जो मेरे मदर के किडनी की वजह से हुए हैं। सो आप आगे आके आपका खुद का ऑर्गन अगर डोनेट करते हो तो जिसको ज़रूरत है उसको दूसरा लाइफ मिलता है।
किडनी ट्रांसप्लांट, लिवर ट्रांसप्लांट, हार्ट ट्रांसप्लांट, लंग ट्रांसप्लांट, ये सब लाइफ सेविंग ट्रांसप्लांट्स है। ZTCC का प्रयास रहता है कि लोगों में ये अवेयरनेस क्रिएट करें। पिछले 5 सालों में हम देखते हैं कि ये अवेयरनेस बढ़ती गई है और हमारे नंबर ऑफ डोनेशंस भी बढ़ते गए हैं और हम आशा रखते हैं कि यही प्रोसेस से ज़्यादा लोगों को हम हेल्प कर सकें।
Thanks, madam, for that enlightening video. I think people who have been staying and enjoying till the end would have definitely got some insight into how to get into the kidney allocation and organ donation program, both live and disease donor. So truly appreciate who all have attended the program. This was a long 2-hour program, but we had exciting sessions in the form of quiz, panel discussions, and about how to become a donor. Some good answers to how to go about with a disease donor transplant, and last but not the least, exciting video. So I thank all the panelists. I thank all the moderators. I also thank all the participants greatly who had come in great numbers. Also thank MCure Pharma to have hosted this, and we are able to get the video recording done of the whole session. Special thanks to Lavi Gaur. Special thanks to Shruti Madam who conceptualized the whole thing and has given a good shape to it. Good numbers. I hope in coming days the video will be well appreciated and well seen by many who could not attend but will get an opportunity to view them.